Hello and welcome today to ACM Tech Talk. This webcast is part of ACM's commitment to lifelong learning and professional development, serving a global membership of computing professionals and students. I'm Marco Grutese, the Peter Gerazio Faculty Scholar and Professor of Electrical and Computer Engineering at Rutgers University in the Wireless Information Network Lab. My research interests are in mobile computing with applications in automated and connected vehicles. I'm also a research scientist at Google AI, working on federated learning. I'm further an ACM member, ACM Distinguished Scientist, and currently serve as chair of ACM SIG Mobile. To learn more about my background, check out the bio widget on your screen. For those of you who may be unfamiliar with ACM, here's more information. ACM offers educational and professional development resources that bolster skills and enhance career opportunities. For example, through a range of ACM Learning Center resources at learning.acm.org. You can see some of the highlights on your screen. ACM provides timely computing information published by ACM, including communications of the ACM and Q magazines, access to the ACM Digital Library, the world's most comprehensive database of computing literature, international conferences that draw leading experts on a broad spectrum of computing topics, support for education and research, including curriculum development, teacher training, the ACM Turing and ACM Prize in Computing Awards, and the newly updated ACM Code of Ethics, a collection of principles and guidelines designed to help computing professionals make ethically responsible decisions in professional practice. ACM enables its members to solve critical problems using new technology that enriches our lives and advances our society in the digital age. Before we get started, I'd like to quickly mention a few housekeeping items shown on the slide in front of you. First, the slide will advance automatically through the event. On the bottom panel, you will find some additional widgets and resources. If you're experiencing problems with the slides or audio, press the F5 key in Windows or Command R if you're on a Mac, or refresh your browser on a mobile device. Or you can close and relaunch the presentation. To control volume, adjust the master volume on your computer. If you have questions during this talk, please type them in the QA box at any time and click the submit button. I'll organize the questions while Shwetak speaks, and he'll reserve time at the end of the presentation to address them. This session is being recorded and will be archived. You will receive an automatic email notification when it becomes available. And check learning.acm.org for updates on this and other upcoming webcasts. At the end of the presentation, you will see a survey open on your screen. Please take a minute to fill it out to help us improve our tech talks. You may also open the link on the survey at any time from the resources window on your screen. You can use Facebook and Twitter widgets on the bottom panel to share the presentation link with your friends, as well as tweet comments and questions using the hashtag ACM Learning. We'll be watching for your tweets. We also have a new community discourse page to continue the discussion after this webcast, including questions we won't be able to get through during the Q&A session. This brings me to today's presentation. Today's presentation is The Emerging Role of Mobile Computing in Health by Shwetak Patel. Shwetak Patel is the Washington Research Foundation Entrepreneurship Endowed Professor in Computer Science and Engineering at the University of Washington, where he directs the UbiComp Lab, which develops innovative sensing systems for real-world applications in health, sustainability, and novel interactions. He's also a director at Google, working on healthcare. His numerous honors include the ACM Prize in Computing, a MacArthur Fellowship, a Sloan Fellowship, a Presidential Early Career Award for Scientists and Engineers, a MIT TS35 Award, and the National Academy of Engineering Gilbreth Award. He was also a co-founder of the home energy monitoring company called Sensi, acquired by Belkin in 2010, a low-power home wireless sensing company called Snoopy Technologies, acquired by Sears in 2015, and a mobile health company called Sanosis Health, acquired by Google in 2017. He's also a member and fellow of the ACM. Shwetak, without further ado, take it away.
Great, thank you, Marco, for that introduction, and welcome to today for the presentation. This is kind of an interesting presentation that I've put together for the broader computer science community. One of the things that I want to focus on today is talking about the kind of the role that computing can really have in healthcare, and just one flavor of that. Obviously there's many different ways you can think about impact in healthcare with computing, but mobile computing is kind of an emerging area. So I wanted to just talk about kind of the opportunities here, some of the research that my lab has been doing, but also encouraging future researchers and scientists and researchers in academia and industry to kind of think about what the role that computing can have in healthcare in general. So I want to focus a little bit on that work, but before I do that, I want to just kind of give an overview of the work that I've done in general at the University of Washington in the lab, on the applications to high impact areas. In one area that we've done a lot of work in the past is energy monitoring. So looking at how do you use simple sensors and low-cost sensors and combine that with AI and machine learning to be able to provide people with feedback on where they're using energy, where they can reduce energy usage or water usage. So that's an area we've been working on for some time now in sustainability. A lot of work in low-power wireless sensing, so looking at new sensors that you can develop that can really help push this vision of having sensors distributed in an environment to be able to in more real time and more effectively detect what might be happening, be it in a building, be it in a bridge, or in a home itself. Looking at a lot of work in interaction techniques. So if you think about the emerging mobile platform or devices that are on the wearable form factor, the standard UI technologies that you've developed that metaphor don't really apply design technology to be able to interact with a small screen where you might not even have a keyboard. So looking at a lot of work around interaction techniques. And more recently, we've actually put a lot more emphasis on healthcare. So now looking at how can we leverage electrical engineering and computer science as tools to be able to solve some of these grand challenges in healthcare. So this is my broad research area where my lab is fairly broad, looking at a number of different areas, but the key has really been looking at how do we marry low-cost, highly deployable sensors with machine learning to provide insights and capabilities that were once not thought of possible with just a conventional sensor, or if you had to build a customized sensor. So really trying to figure out how we can enable scale by using the combination of signal processing, machine learning, and sensors. So what I want to focus on today is some of the work that we've been doing in healthcare. Really the goal that has been driving a lot of the work that I've been passionate about is looking at how do you bring more of the healthcare interaction that you would typically think about, where it's typically, clinical encounters, how we often think about healthcare. You go to a doctor's office, you have an encounter there where, you might have a follow-up from an issue that you might have had, or you might have just a kind of a general wellness or a checkup. But how do we start to bring that into the home or bring it into the life of individuals where it's kind of out, when people are out and about? How do you bring the clinic into one's pocket, or how do you bring the clinic into one's daily life where they're able to maybe interact with their health more effectively, where right now it's very sporadic, right? When you interact with the healthcare industry or the healthcare system, it's really around those checkups, or maybe every now and then you might have an acute issue and you go in. But how do we start to make that more into a more frequent interaction where you can essentially try to, one, get ahead of disease, so before something happens pre-symptomatically, but also if you have an issue that's arising, how can you immediately start to address that without having to, really think about going into the clinic for that care? A lot of things that you can think about for acute care, even for some chronic diseases, you can start to manage this outside of the four walls of the hospital. So how do we start to enable that, the world? So if you think about healthcare, you think about healthcare, there's a lot of major paradigm shifts that have happened. You got to point to a number of vaccinations, drugs, therapeutics, but one particular area that was really a big paradigm shift for healthcare was this notion of point-of-care diagnostics. So the ability to be able to diagnose a disease or diagnose a condition at the moment that somebody is actually seeing a physician really revolutionized how we start to administer treatment more effectively. So here's an example of an ultrasound machine. This is an ultrasound machine that's pretty dated. These days, they're even smaller. In fact, you can find one that attaches to a mobile phone. But the computational power in this device was that of a phone that was just maybe 5 years ago. So if you think about the computational horsepower and the capabilities on a modern phone, they actually surpass that of a lot of these medical devices these days from a computation standpoint. And even an interface standpoint, you have these abilities on a phone too. But point-of-care diagnostics, the being able to diagnose something when somebody comes in, really revolutionized how do you actually get somebody to treatment. Now we're actually in the midst of this another major paradigm shift, which is how can the phone be at the center of a lot of the work that we're trying to think about in healthcare. So we're already seeing this trend in terms of having devices and peripherals that attach to a phone that can enable these kinds of things outside of the clinic. So here's an example of a pulse oximeter that connects to the microphone jack of a phone that basically provides the same capabilities you might find in the clinic, but now you're leveraging the computational power of a mobile device, the networking capabilities of it, the user interface to basically generalize that portion out, and you're providing specialized sensors into it. Now you can start to do pulse oximetry for at-risk patients that might not be in the clinic. And now you can start to enable new use cases where you can start to empower community health workers in a global health setting, rural communities where they might not have access to certain clinics or certain types of devices. Now you can start to democratize that across a broader sector. So you're seeing this trend. And on top of that, you're seeing this trend, which is the wearables movement, looking at how do we start to get access to biosignals and information from the body. So watches are an example. Many of these things are things that you can wear in a pocket, you might have on the body. Some of these are sporadic, so you kind of use it once or twice a day, maybe once a week. Some of these are continuous, so you might see something like the Life Shirt, which basically captures ECG continuously. So this is another area that's emerging and blossoming because of the ability to start to develop embedded systems that are actually cost-effective and scalable, so you can actually start to do some of this stuff. Battery life is getting better. Embedded technology and algorithms are getting better, so you can actually start to have a bit more of this continuous measurement. And that's kind of one of the holy grails of kind of computing has been looking at how do you enable that. So another area is looking at mobile phones. So this is a picture of a TED Med. TED Med did an event about probably 7 years ago. So these are a bunch of different projects that actually came together and said, hey, you can do a full physical just using a smartphone. Some of these are just using the sensors on the phone. Some have attachments. But this just gives you an example of 7 years ago, there was already enough technology that was already being developed to actually do a full physical. It's hard to see in the background, but that's actually a former Surgeon General, Regina Benjamin, who's actually getting a physical with using mobile phone devices. So getting her heart rate or blood pressure with some attachments to a phone, but you can kind of see where this world was already kind of evolving. And one of the opportunities with mobile health is that there's a number of things, if you think about care outside of the hospital, chronic disease management, after you've actually been diagnosed with a disease, how do you help somebody actually manage their disease? Going beyond just the checklist that you have to go through. Like, how do I know that I'm actually doing better? Or how do I know that something's getting worse and I should intervene sooner? Screening tools, being some at a population level, how do you start to get screening tools out there so you can triage and get the right people into the clinic? Also discovering new diagnostics, being able to get access to signals and biomarkers that can actually be predictive of certain kinds of health conditions. So for example, what would it mean to be able to detect the flu pre-symptomatically? What are some of the, not just risk factors in terms of where you reside and where you might be in terms of infectivity, but are there other health conditions that might be arising or symptoms that might be arising that might allow you to detect those things ahead of time? And also the evolving patient-provider relationship, enabling a way so that the provider, the physician, can empower the patient to be able to take a lot of the healthcare burden on themselves to be able to monitor this, or at least provide the feedback that the provider needs to be able to provide better care. So really trying to evolve that relationship between it, where it's a mutual relationship rather than just a one-way where, hey, I go to the clinic and I get diagnosed or screened or treated. How can I start to bring that back outside of that clinic? And a lot of this, the hypothesis has been around continuous measurements. If you have a time series, you might be able to detect things ahead of time before sometimes some people are symptomatic. But I think before we get into that world of continuous measurements, I think just being able to bring healthcare, at least measurements and those kinds of things outside of the clinic is the first step. So we've already kind of seen this a little bit in the mobile health space. There are a number of different apps and projects out there that start to do patient-reported outcomes where you might do a survey, or you might have survey in terms of how you're feeling or symptoms and those kinds of things, where you manually input into an app. Here's an example of an app where you can start to look at your caloric expenditure based on your movement, but also caloric intake in terms of journaling what you're eating. So there's already mechanisms right now, there's apps that help kind of manage one diseases, or if you have a treatment or a plan that you're working on, be it nutrition or diabetes management, that you can kind of consolidate into the app. And the phone is a really powerful platform. The ubiquity of the phone, in terms of the most ubiquitous, consumer electronic device out there, it's a very powerful thing. It has networking connectivity, it's got a user interface, and people's affinity to the phone is pretty spectacular. And so this is a platform that could be really interesting. And if you dive one notch deeper, the emerging sensors that come out on the phone. Most modern smartphones, even the smartphones that you can find globally, are starting to have more and more capabilities. Now you start to see a camera and flash, but now you can see them on the front and the back. You have multiple microphones, speakers. You have pretty much 3 or 4 radios in there. You have a capacitive touchscreen, accelerometer, gyros that are very sensitive and powerful. But often these things have been designed for specific use cases. It could be for gaming, or it could be for changing the landscape portrait mode when you're taking a picture or viewing something, telephony, productivity. But as these sensors are getting lower and lower cost and better quality, there's this ability to be able to leverage those for other use cases. For example, if you think about the camera, most modern smartphone cameras can rival the photography that of higher-end cameras. And if you think about the computational capabilities in this device, you can start to use these cameras for other kinds of use cases. And healthcare is one of them in terms of imaging and being able to use that for screening and those kinds of things. And using other sensors like the capacitive sensor or the speaker and microphone in unique ways could actually enable to be able to diagnostics and screening outside of the clinic. And that's really what the work that we've been trying to enable is, how do we start to drive scale with very simple software updates on a mobile device to at least make us, at least provide some inroads into this space. And so we've been looking at how to use existing sensors on phones for healthcare sensing, and really try to push the boundaries in what you could do with these things to drive future innovations on customized devices, maybe looking at new diagnostic technologies that are even lower cost. So if we can push the boundaries on a phone, we can start to democratize how we can get this out there, but start to actually have secondary impact of that by building specialized devices over time. And so we've been working in this space for about 7 years now on a variety of different projects. A lot of these areas include looking at the pulmonary space. How can we uniquely use the speaker for identifying disease in the pulmonary space? Chronic asthma, COPD. We've also looked at a number of different areas on non-invasive blood screening by using the camera and flash to see, well, what kind of things can we get? What are the constituents we can actually analyze optically with the modern smartphone? So we've done things like hemoglobin or bilirubin in the blood, cardiovascular disease, SpO2 monitoring, pulse transit time as a proxy for potentially blood pressure, or other kinds of things like arterial stiffness for cardiovascular disease. Looking at other disease-specific use cases, looking at using the speaker for things like when people are snoring or breathing differently, or things for a sleep apnea assessment, looking at osteoporosis even. So I'll talk a little bit about that towards the end. I'm using the accelerometer and gyro as a screening tool to potentially get at bone density. So these are things that are kind about what you can do with a phone. When you look at it from the speaker, and if you're able to apply machine learning on that data stream in unique ways, you might be able to get at some of this information as for screening possibilities. So I'll go through a bunch of different examples. So really the goal today is to talk through kind of what's possible, just really spur creativity in the space and get researchers excited about what you could actually do on the mobile platform. So one of the areas we've been doing a lot of work in has been lung function. So looking at how do we start to use a speaker and a microphone, or primarily the microphone, to basically help people with various amounts of various conditions around lung function. So spirometry is kind of the mainstay in terms of monitoring respiratory conditions. So if you have asthma or COPD or cystic fibrosis, spirometry is how you measure your lung capacity, how well is your lung doing, to be able to diagnose disease, to see how treatment is machine, and it gives you a lung function assessment. These are typically reserved in the clinic, but you have home spirometers that are dedicated devices. But the problem with those devices is that you might not have it with you. There's compliance issues. It's just, you might not have it at the time that you might need it. Why you might be having an asthma attack, or you might feel like you're about to have an exacerbation. That thing might not be nearby to really figure out how you're doing. So looking at in-home treatment, or looking at in-home monitoring, those technologies really are hard to kind of get there unless you have a specialized devices. So one of the things we started to look at is, could we do this with just the microphone itself? So we worked on a project called SpiroSmart, which basically uses no additional hardware. In fact, it doesn't even have a mouthpiece. That's done by using audio analysis of the microphone when you do a respiratory maneuver. So in a lot of these cases, what you do is you take this device, you blow into it as hard as possible, you try to pull all the air out as possible, and you try to get an assessment of how much air can you push out on over a certain amount of time to be able to assess how your lungs are doing. And so that's what we want to do, is replicate what can you do with a clinical spirometer on a mobile phone. And so basically the way this works is that you have a phone, you hold it in front of you, and you blow at the face of the phone with your mouth open, and you're actually trying to get that assessment where we're trying to sense how much air is coming out of there through the microphone. And we have a visualization that helps you nudge you to push the air out harder and faster, because one of the things that's critical here is that the technique makes a lot of difference. So while you're doing this, the visualization will tell you, keep going, or, open your mouth, you're closing your mouth. So you can actually provide that real-time feedback so somebody actually can do this maneuver properly. But that was really the goal of SpiroSmart. And the way that we actually solved this problem was that, if you look at a traditional spirometer, is that it uses a flow sensor. It could be a turbine, it could be a pneumatic, but basically you're detecting airflow through an orifice, and you're basically trying to use that as the measure of airflow coming out of it. But the question for us was that, for a microphone, there is not that. We don't have a microphone is basically an uncalibrated pressure sensor, so we don't actually have flow out of there. So what can you do there? So one of the things we actually did was we actually went back to some of the fundamental work in speech processing and looking at things like vocal tract resonances. This is research in the computer science community that for a long time, a lot of the researchers were trying to cancel out that noise, right? When you're actually doing natural language processing or speech processing, it's those resonances from the vocal tract that actually causes problems for a lot of the algorithms. But what we said was, could we flip that on its head a little bit and actually look at that noise? Because what happens is that when you have obstruction or restriction that causes a change in your airflow, it actually the vocal tract resonances are the things that you can actually hear. So you can actually use the human body as the sensor. So if you have an obstruction, those resonances are actually telling you how much air is either flowing or not flowing. And so that could be actually indicative about, can be a proxy for the amount of airflow. And so this is something that is kind of an interesting thing that kind of permeates through a lot of the work that we do, is often a problem for one particular domain could actually be a solution for the other. So the noise in the speech recognition world actually became the sensor solution, or the signal that helps us identify obstruction and restriction for pulmonary ailments. So that's just something to think about, where when you're looking at problems where it's a lot of times that the thing that you might be canceling out or trying to detect could actually be important for another use case. So what we did was we created a vocal tract model that basically we modeled the mouth, the glottis, and the vocal tract to create kind of a physics model to basically try to figure out, well, when you hear the sound, how can we back calculate out roughly what's happening kind of from a physiological standpoint? So I'm not going to go into the detail for this because I just want to give a cursory view of a lot of these different projects, but that's essentially what we did. We actually created a vocal tract model to be able to infer the airflow coming out of an individual. So we actually did another project that kind of was a offshoot of this as well, which was looking at how do we start to do this without a smartphone. So the previous project was looking at how do you do this with a mobile phone that has the capabilities of processing it on device or has the microphone that's capable of doing that. So we also did a similar effort around using the mobile phone, using a kind of a feature phone, so something that's not a smartphone, but how can we do this over the air? So if you dialed a 1-800 number and did the same maneuver over a telephone network and modeled the telephony network to see what would happen to that signal, could we start to get at the same information? So literally doing it from a global health standpoint, could we literally use any phone in the world to be able to do that? So those are two parallel efforts that we worked on. And kind of fast forwarding a little bit is that we did a clinical study of this, a fairly large clinical study, about 10,000 patients, where we actually did an evaluation of this, where we had people with a variety of different lung functions, people that were healthy, people with chronic asthma, people with COPD, and did an analysis using it's a telephony network to get that sound across to a server where you can post-process it. And so the bottom here are just kind of the measures that the clinicians typically care about: forced vital capacity, and look at, for example, is FVC. So this just is the Bland-Altman plot. But I want to direct your attention to the top graph in terms of the error. So if you took a clinical grade FDA-cleared device and you compared it to our algorithmic approach, it's actually, if you look at all these measures, both for a device that's a smartphone or even a feature phone, you're still within 5 to 10% error within a clinical grade device. So what that means is, it's not perfect. It's not going to get you to a particular FDA grade tool, but as a screening tool, this is more than sufficient to be able to do a screening in a clinic and then send you to a pulmonologist to basically say, hey, you're within the kind of the warning zone, so we should now to a large number. One could argue that the 5 to 10% variation is the natural variation you might see with a clinical spirometer already. So we're actually in the midst of looking at how do we actually go through an FDA process to be able to start to validate and clear some of these things for actual diagnosis purposes as well. But this just tells you the power of what you can do with a simple microphone if you just look at the problem slightly differently. But this is an area that we've been working on for some time now. There's an area that's been similar to this that we also worked on, is looking at how do we use the microphone to also detect and study cough. So coughing is a kind of a symptom that often, if you talk to a clinician about it, that's one of the primary symptoms you kind of hear about when somebody has a respiratory, acute respiratory condition or anything like related to the flu or something like that. But it's not very quantifiable. And in fact, clinicians often don't think about a cough as a useful signal. It's like, yeah, everybody coughs, but what can I do with that? But we wanted to study this a little bit more deeply because our hypothesis was that, hey, the cough can actually tell you more about a disease because it's actually a reaction to something that's going on in the pulmonary system. Whereas most physicians may not think much about that because, oh, it's a cough. I can't really think about what's going on there. But the hypothesis was that the human ear may not be able to pick up these subtle changes or subtle characteristics of the cough that really tease it apart from one cough and another. But a machine learning algorithm can actually start to dive in a bit deeper in terms of looking at different frequencies and resonances, look at the time series. There's other things that we could potentially zoom into that might give us that discriminability to be able to say, hey, cough can give us something. So we had a number of different projects that we worked on here. One is let's quantify it. So if we could just accurately count how often people are coughing, what use could that be? So if we just knew coughing episodes, and then take it to one step further is, hey, is there any differentiability in the cough itself? And so one of the things that we've worked on was looking at, well, first, how do we actually detect cough? So we actually went back to that original model and that glottis model that I presented in SpiroSmart and looked at how can we create an accurate algorithm that can segment coughs and do this in a privacy-preserving way where you can do it on device. You're not streaming the raw audio to some server. You can actually do it on device so that you can start to segment where the cough happens so that you can do it in a very privacy-preserving way where if you played back the cough, you're not going to hear any intelligible sound. There's no speech. It's just the cough. So that's what we did, was built a very accurate cough detection model for privacy-preserving reasons. And then you could take that segment of the cough and do further processing to see, hey, now can we think about what kind of cough is it? Is it a wet cough, dry cough? Is it a productive cough? Is this cough indicative of tuberculosis versus pneumonia? And start to do further processing on this. And so we built a convolutional neural net that first did this and then actually converted this to an RNN that was a little bit more explainable. But this neural net can actually accurately extract this particular cough frequency. And one of the things that we've done with this is basically been able to use this for studying COPD. So if you have a patient that actually has been diagnosed with COPD and they go back home, if you can just count in the evening how often they're coughing. And if the cough gets worse, you can actually get ahead of them actually having an exacerbation before they go into the emergency room. So you can actually do this in a way that you can start to track the progression of a particular treatment. Same for tuberculosis. If you have somebody treated with TB, is their chemotherapy treatment actually working or not? Just by frequency, how often they're coughing. But we wanted to actually study this a step further. So we actually been working with the Gates Foundation to look at how do we study tuberculosis, where it's a highly infectious disease. The spread of TB is still being studied, but coughing is a major symptom of it. And so one of the things we wanted to do was, could we create an acoustical biomarker for tuberculosis? So in other words, when somebody coughs, could we, with some level of sensitivity and specificity, detect that cough sounds more like a TB cough than a pneumonia cough or an influenza cough? And so the reason why we thought this was possible is if you look at the lung on the right, is these granulomas form. So when you have tuberculosis, these granulomas or these holes are forming in the lungs as the white blood cells are trying to attack the disease. And these granulomas actually cause a change in the airflow out of the lungs. And so the hypothesis was when you cough with those granulomas in your lungs, your cough has to sound different because the geometry of your entire lung and the respiratory system has now changed. And so that's what we wanted to do, was to dive deeper into what we were doing in terms of studying that cough. So the results have not been published yet, so we're about to publish these results. But what I can say right now is that we're actually starting to see sensitivity and specificity that's actually on par with a sputum test. A sputum test is when you cough up phlegm, and then you do an analysis on that particular sputum. And the reason why it's starting to it's on par of that is because sputum tests are very difficult to do, because a lot of times people don't cough up really good sputum. You have to really get to the lower part of the lungs to be able to cough that up. So there's already error in getting the sample altogether. So when you look at combining that kind of with the work that we've done thus far is looking at cough identification. So if you look at the CNN approaches, when we can start to get to true positive rates at about 0.95, 0.98, which is really small, really low false positive rates. So true positive rates, meaning that we can identify when somebody's coughing without having a lot of background noise like a door banging or a backfiring car or loud sounds coming through, because you got to be able to segment the cough really accurately so that you can take it to the next layer classifier. So this is work that we've been doing for some time, where we've been able to also build these on-device models to be able to do this very accurately in terms of identifying the cough and being able to be sure that that's actually a cough. So this is one area that we've been looking at for some time now, is leveraging the microphone for unique things in terms of respiratory ailments. The other area that we've been looking at has been looking at the camera. So the camera, and to try to see if we can do blood constituent analysis. Obviously, you can't do everything with that, where you have to have at the molecular level, you might have to do something. When you look at peripheral blood, what are some of the optical techniques you can leverage there? I mean, some of the simplest thing you can do is basically know your heart rate. This is an assignment that I give some of my students in my class, where build a heart rate monitor that uses the camera and flash on your smartphone to be able to track your heart rate. So, the blood basically is red. You can actually see the cardiac volume changing as the heart is beating, and that's a very simple algorithm you can actually build. But now, because modern phones have a flash that's a white flash that has a broadband spectrum, could we start to look at other spectral properties to try to get a sense of, could we start to get at the constituents in the blood? So one of the projects we did was an application called BiliCam, which uses the mobile phone to address newborn jaundice. So newborn jaundice is when babies are born, they look yellow, and they're yellow because of bilirubin building up in the blood. So, their livers are still developing, and some babies basically develop this thing called jaundice because the bilirubin is a byproduct of the dead red blood cells that are not being essentially garbage collected by the liver. And so what happens is this starts to build up in the blood. And so you have to actually monitor this very closely. But instead of having to do a blood draw, could we actually enable a parent to be able to just use the camera and flash to figure out how much bilirubin's in the blood? And the reason why we thought this was a good starting point is you already optically see this visually. They kind of look yellow. So what we're saying is, instead of just looking at the yellowness of the skin, could we start to look at what's causing that yellowness? And the reason why this is interesting is that, right now the gold standard is you do a total serum bilirubin. It's basically pulling blood out of the body, because you do a blood test. There's actually a device on the market that actually can do this non-invasively. So Philips makes a device that you put it against the skin of a baby, and they can optically try to figure out how much bilirubin's in the blood. And the reason why you can do that the spectral properties are actually kind of known. So we're like, if there's actually a non-invasive device that can do it, smartphones should be able to do that. The reason why this is actually interesting to do on a smartphone is that when a baby is discharged, their bilirubin doesn't actually peak until 2 or 3 days after they're born. So a lot of times, the parents and the baby have already been discharged from the hospital, and so the level of bilirubin actually doesn't increase until they actually have left the hospital. So it's not actually easy to screen them because they're not at the hospital anymore. They're actually at home. So a lot of times parents are asked to do visual assessment. Hey, does your baby look yellow or not? And that's a very hard thing to do, especially if you have babies with different pigmented skin. So we wanted to create a tool that allowed people to do this at home. And so the idea was, could we actually start to do in-home monitoring, that you could monitoring of bilirubin, because this is something that peaks when you're at home then. So if you look at bilirubin, one of the things that it's known is that it actually absorbs blue light. So bilirubin has a spectral property where the absorption of blue is actually really high. So if you knew the output of the light coming out of your flash, and you kind of use the camera to basically image, what happens when you flash light at it, you can actually start to figure out how much bilirubin is actually in the blood. And that was kind of our hypothesis. So what we did was we actually created an algorithm that basically took pictures of babies. So we actually consented patients where they had a newborn and they had their blood draw, and we actually had nurses take pictures of these newborns. And in the top left, you can see there was actually a calibration card there as well. So all you have here is a calibration card that basically calibrates for the ambient light. So it also helps for range finding too, to make sure that the phone is held at a consistent distance, and and there's a hole in the middle of the card so that you got the skin patch. So you got the skin patch, the light's incident on that patch, and because you have a card, you can make sure that the phone is held kind of planar to the baby. And so the idea is that you would take a picture of the sternum of the baby, and then that little patch gets cropped out, so the eyes and none of that is processed, just that little skin patch, and then the image processing is done there. And we actually did multiple techniques, but some of the algorithms that in the end were some of our RNNs that we developed using this approach. You can kind of see what the accuracy of that was. So in an initial trial of 530 newborns across the United States, so this included babies, light darker babies, babies that had a number of different pigmentations. We looked at, and TC is the non-invasive device that Philips makes. Their correlation to the blood draw is 0.92, and Billicam is very close. So it's actually, you can demonstrate that you can get very close with a commodity smartphone to a general purpose device like that, very close to a dedicated device like a bilirubinometer. So on the bottom is the Bland-Altman plot. And so when you look at this, one of the things you can think about is that you can now start to use this as a screening tool at home. So if you start to get into the high, basically when babies start to get treated or basically do a blood assessment there. But now we can start to enable screening outside of the clinic. This actually has huge impact and implications for global health, where a lot of times if you might have a nurse case manager, or if you have a midwife where we might not have a baby born in a hospital, then that tool might not even be available. So now you can start to empower community health workers to be able to do this kind of screening at a massive level, where you can start to use this as a case finding tool. So this is an example of using the camera and flash for that. Another area that we looked at was using the same bilirubin technique, but in adults. So when we published some of these results, there's been the research community kind of reached out to us and said, hey, bilirubin in the eyes of an adult might actually be interesting, especially potentially for pancreatic cancer. So one of the challenges about pancreatic cancer is that a lot of people are symptomatic. Have pancreatic cancer. By the time they're diagnosed, when they're symptomatic, it's usually too late. So pre-symptomatic, you don't know something's going on, and by the time you're symptomatic, it might be too late. And that's one of the reasons why the 5-year survival rate is very low. And so one of the things that we started to look at was that there's this hypothesis that you can actually start to see in adults, and babies you can actually see it in their skin, but in adults, people with pancreatic cancer or other kinds of liver diseases, you see a minute amount of jaundice building up on the white part of their eye, the sclera of the eye. Their skin might not look jaundice, but adults, because it's so minute, you can actually start to see it in the sclera. So we actually adapted the Billicam algorithm and did a clinical study where we had patients that were diagnosed with pancreatic cancer, and to see if we could detect the jaundice in their eye. And we could. You can actually see it just by taking a selfie or taking a picture of your eye, by looking at how much of yellowing you're seeing, and actually in milligrams per deciliter, figure out how much bilirubin's in there. So we did a study that basically could be as a screening tool to say, hey, there's elevated bilirubin in the eye. Could we get that checked out? So the implication of this is that you could longitudinally just look at scleral images over time to see if somebody that's at risk, if you have a family history of pancreatic cancer, or if you're at risk, you can start to use this as a very simple screening tool to basically indicate that something might be happening. And so the ability to do this is very interesting, because now you can start to use a very low-cost device to try to see if you can try to get at some of these conditions pre-symptomatically. So that's just kind of a aside I want to mention on what you could do with use this technique for adults. And another area that we've looked at is hemoglobin. So again, looking at using the camera and flashing in a unique way. The way that this project works is that hemoglobin has this property where you can actually start to tease apart the plasma and the red blood cells, and you can have a similar optical response, just like bilirubin, but it has a different optical response. So the way that Hema works is you use this phone and you put your finger over the camera and flash. You don't take a picture of the skin. You actually put your finger over the camera and flash, and then you basically use the peripheral blood, the arterial blood there, there to be able to do do an optical assessment there. The idea behind this is that if you look at spectral properties, the way of plasma and hemoglobin, you can actually start to tease apart the ratio. So for hemoglobin, you kind of want to know how much hemoglobin is in there relative to the other stuff in there, so the plasma or the water in the blood. And this is important for people who are anemic, right? If you're getting anemic, for anemic individuals, you got to monitor your hemoglobin. So pregnant women that might be anemic, people with chronic anemia, people with sickle cell anemia. So without having to pull blood out of the body, can I just get my quick hemoglobin level? And again, there was also a device on the market that did this non-invasive with a customized device that shot specific frequencies of light into your finger, and you can actually look at the absorption properties there. But what we said was, could we just use the wavelengths that are available on a broad brand white LED to be able to do this? And so that's what we did. We kind of looked in the visible range of what a white band LED could do and found a couple points on the absorption graphs to be able to analyze that. So what we're looking at is the absorption, the reflection of what plasma and hemoglobin have, and just do the ratio. So you really care about the percentage of hemoglobin in the blood. And one of the challenges here was that how do you do this in a way that's skin tone agnostic? And the way we did that was that, obviously your skin tone is not going to be changing within a few seconds or a few minutes, skin color. So what we do is, because we can see the heartbeat in the finger, just like how I mentioned, you can get, you can monitor your heart rate just by looking at the cardiac volume, the throbbing that you see when you image your finger. So you can do this experiment at home. You can actually put your finger over your camera and just record it, and you can kind of see your heart rate. And that's an easy experiment you can actually do at home right now. And so what we can do is we can see your heart rate. And so we know the changes that are happening because of your heart beating. That's not because of the changes in color. So by looking at the differential, we can say, hey, this signal is actually the blood moving through your hand or your finger. So now we can start to lock onto that. So by looking at just when the heart's beating, we can actually look at what's changing in terms of the cardiac volume, what's not changing because of the skin color, and then we can lock onto the hemoglobin that way. And so, so this isn't going to come through this chat, but this is actually supposed to be a video. But you can actually see the subtle changes in terms of the color. And then what we do is, when the color gets brightest, we can image it there, or when it gets lightest, we can image it there. So we actually know exactly what contributed to the change in the finger color, which is blood, or what was their baseline. So again, you can do this on any smartphone that has a flash, where you can actually see your heart beating if you record that at a high enough frame rate. So we did a clinical study. These results are a little bit older. We've done more patients than this, where we took this approach and compared it to a FDA-cleared device that's on the market, and that's a non-invasive clip-on sensor, and phone-based approach. I'm going to plot below. You can also start to see, there are some things that it over and under predicts, but as a screening tool, again, this could actually be a first level of kind of defense to be able to massively be able to deploy this. And so this is one of the things that one of my graduate students has been working on, Edward Wong, is looking at how do you use this as a screening tool for kids with anemia. So he's actually working on a project with the Ministry of Health in Peru, looking at, hey, one of the challenges in Peru is that a significant portion of the population, especially for kids, are anemic. So how do we create a tool where we can quickly go to the jungles of Peru and to these low-resource communities to be able to triage and get the right treatment as soon as we can? But that case-finding tool is really tough if you have to have a blood draw for all of these different regions. And so you can see an example of him using HemaApp to be able to do massive screening of people on the right, where you just line who are actually want to try to prioritize to be able to get to the next level of diagnosis. So this is one of the examples you can do if you were able to deploy something like this at a larger scale. And then I want to talk a little bit about the osteoporosis, and this is kind of early work we're working on now, but this is using a whole different set of sensors. This is using the gyro and an accelerometer in a phone. So osteoporosis is basically a hollowing of the bone. So basically, if you have osteoporosis, you basically have the likelihood that you're going to break a bone very quickly or more easily. So on the left is a healthy bone, on the right is an osteoporotic bone, where you have a reduction in density. The idea here was that this was actually one of the grad students that found a paper in the 70s where there was a very clever doctor that basically figured out, hey, how do we start to do osteoporosis? How can we do osteoporosis screening without having to do an X-ray? So that's what happens now. You actually do a radiology scan. It's called a DEXA scan. So you basically image, the femur or the arm, and you basically do a radiology report to basically say, hey, how hollow are the bones, or what's your likelihood that you might have a bone that breaks. This is a 1 to 5 scale that you can actually start to say that you're osteoporotic or not, your bones are. But instead of having to do a radiology scan, are there other ways to do that? And so one of the things that this doctor came up with was, hey, you can actually take a tuning fork, and then if you resonate the hand in a certain way, the tuning fork could actually make a sound if it's a healthy bone. If it's not a healthy bone where there's actually a reduction in density, that tuning fork or that apparatus won't make a sound. So they're trying to mechanically resonate the arm so that you can actually hear the sound or not. So it's very much a binary thing where, hey, mechanically there's something different about the porosity of your bones. And that's where we start to drive some inspiration on, hey, no, modern phone, you can actually run the accelerometer and gyro in a way that you can sample this at 1,000 hertz. You might not need to with conventional use cases of the phone, but hey, for this kind of use case, you could. So the idea here was that you take the phone, you grab it, and you create an impulse response. So you can tap your elbow. You might take one of those medical hammers where you can actually tap the elbow or the knee. And could we create an impulse response and detect from the accelerometer and gyro what are the resonances that are being captured at the hand? So the hypothesis is that if you have a hollowing of the bones, certain resonances won't actually get through. And so here's an example of what that looks like. So if you have a healthy bone, you have all these sub 400 hertz resonances that go through. You have a perfectly healthy bone. You can basically see those ripples that are happening. So you've got an impulse response that's broadband, and you have these resonances that occur a half a second, 500 milliseconds onward later, and you can start to see that, hey, you still see these ripples that are happening. That's indicative of a healthy bone. But what happens with an osteoporotic bone is that you don't actually see those resonances at about 400 kilohertz if you have a porosity in the bone. But what happens is you see the higher frequencies go through. So now you start to see some of the higher frequency tones coming out from that broadband response. So this actually gave us some indication that there is something going on in terms of being able to detect the differences between a healthy and unhealthy individual where the bone is healthy or not. And so we're actually in the midst of doing a study with radiology clinics where you're actually able to get the ground truth through the radiology scans being interpreted and then using the phone to be able to collect that data. So we're still in the midst of doing this analysis. We wanted to just show some initial kind of what the initial inspiration for this work was, and just kind of thinking differently about what it would mean to use an accelerometer and gyro altogether. And if you look at the innovations of these sensors, they're only going to get better and more sensitive. So this was kind of a high-level tour of what you could do with a phone. Hopefully this kind of inspires people to think about this kind of technology broadly. And so one of the things that the implications of this for mobile health, there's a lot of things that I've been looking at. And one is the regulatory space. So some of these things we're actually working through a regulatory process. It's a really different way of thinking about it. How do you make sure that that application, that machine learning model is going to work across different phones, or even the same phone in the same model? So we've looked at ways that you can start to standardize some of these APIs or algorithms. How do you make sure that the microphone response is consistent? So we're actually working with the FDA to help think about what are ways that we can make sure that the thing that you built is going to work across a set of phones. Do you do benchtop analysis to validate across phones? Do you have to validate across every phone? So this is something that's evolving, but there are some ways to actually know that, hey, before this app even runs, it does a stress test on the speaker, microphone, and even the imager to make sure that, hey, is this within spec? Does it have the right resolution? Does it have the right frequency response? There's things that you can do there. So it's safety and trust. Some of the initial feedback that we've gotten from patients and users of this, so it has to be inherently low cost or low quality, right? It's not this gray box that you're used to that is, oh yeah, this has a badge on it, this is a clinical grade device. So really the mental model of, hey, no, this is actually pretty close to a clinical grade device, but the mental model of an app or a phone-based app is it must be low quality because that's kind of how people think about it. So we got to kind of think about what that means to educate consumers about and patients about what that how this world is evolving. And so also thinks about new applications of computing advances. So thinking about, as I mentioned, some of the earlier work with SpiroSmart, where, some of the algorithms that we're looking at, which the speech processing community has been using, we actually took that in a different direction and opened up a whole new area. So being really thoughtful about how we look at innovations in the space to figure out the often think about. And there's a number of other things we got to think about. Right now, I'm just focusing on screening. How do we just get massive amounts of screening out there? But you still got to take into account for things like social determinants of healthcare. I mean, this is not the only way or the only predictor out there. There's been a lot of studies that have shown that your zip code by itself, unfortunately, can be a predictor of health outcomes because of health disparities and all those kinds of things. So there are many other factors that we have to take into account, but this is just one tool that we can pair that up with social determinants and other risk factors that we can start to figure out how we get to treatment to people sooner. So this is just one area in mobile health that it basically focuses on. And then, so one of the charges that I have for the research community is looking at new biomarkers for health. I mentioned some of the coughing work. We're looking at acoustical biomarkers for tuberculosis, but there's so many other biomarkers that we can start to develop and detect using some of the work in machine learning. Mobile phones are going to be effective healthcare delivery platform, and so that's an emerging area. So looking at how we can look at the mobile as a way to deploy and administer care. And then starting to look at, now we can start to build better prediction and models for individualized care. The affinity to the mobile phone, the personalization of the phone to an individual. Now we can start to think about precision medicine, individualized care in very unique ways, and now start to ease into this world of continuous monitoring, which we still aren't there yet to really figure out what we can do with that data. But now if you can move from sporadic monitoring that might be once a year to something which could be kind of more intentional. So I do, hemoglobin reading once a week, or I might do a spirometry reading once a week, to more continuous measurements. Now we can start to kind of scaffold into that world. So that's what I wanted to mainly talk about today, is just kind of inspire some innovation in this area and just talk about unique ways that you can leverage mobile phones. And what I'll do is I'll end by thanking my graduate students. My graduate students and my undergraduate, my current students, my past students, and my future students that will be starting this fall. That without this, none of this would be possible. I'm just a vehicle to be able to talk about this great work. And really, at the end of the day, my grad students and my undergrads and my collaborators are the ones that do the hard work. I've been fortunate to be able to work with great collaborators and students, but at the end of the day, the students are really the key here. So I wanted to make sure that I mentioned that. So with that, I will take questions, and Marco's been kind of taking questions, and he's going to help moderate this. But thank you for your attention, and thanks for joining and listening, and I'm happy to answer questions.
Yeah, thank you, Shwetak, for this exciting talk. And let's move on to the question and answer session. I'd like to start with a question about getting ahead of the disease. That's something that you mentioned early in your talk as one of the big opportunities in that space. And many of the diagnosis techniques that you described target more acute disease. And how do we link this back to the opportunities in preventative medicine?
Yeah, no, that's a great question. Yeah, a lot of these are acute conditions, although some of the measures might be acute measures, but it might still be for a chronic disease, right? But the idea here was just to validate and verify what's even possible in acute, right? It's to really demonstrate the capabilities there, but there's a lot of work ahead of us in terms of trying to get ahead of disease. So one of the ideas here was, if we can start to get some of the acute measures and start to validate some of that, those signals could actually be an indicator for us long term. So for example, hemoglobin, right? So their hypothesis about, hey, if you could do a more frequent hemoglobin assessment, there's something in that time series that could actually detect something ahead of time. But nobody gets a blood draw every single week, right? But now if I can make a tool that's non-invasive, it's easy to actually get a hemoglobin measure every week, now it starts to enable that world of getting ahead of diseases. Now let's create non-invasive, easy to attain measures and biomarkers that allows us to now answer that question. So this is the first step into getting that world, and that's one of the reasons why we start to do that. And the bilirubin is a great example of that. if we first validated what can you do with bilirubin, how can we even do it, and then the liver disease and pancreatic cancer was a scenario where now that you can start to do that study now. Now we can empower the health community to say, hey, now let's use this tool that we've validated to do a longitudinal study of at-risk patients to see if we can detect this. So that was a great question, and I think this is just a tool to now move into that world.
Absolutely. Do you think that will require also developing new criteria for predicting disease and determining disease?
I think so. Yeah. I mean, here's one of the challenges right now is if you think about when you think about the accuracy of a tool, right? It's really the analytic sensitivity specificity that you care about, right? That is or something like that. Now we're moving into the world. It's not just the analytic sensitivity that matters. It's the actual confidence interval, right? It's the confidence interval plus the ROC curve. It's the ability of the sensor plus the contextual data plus other things that are giving us that prediction. That's a different way of looking at metrics, right? And so that's something we have to really think about as computer scientists, is that we got to think about unique ways that put together the variety of things, that the contextual data that we're bringing together. And so I think that's a whole, I think that's something the health community is going to have to start to think about, is there is a different analysis here. It's no longer the analytic sensitivity specificity. It's something different now. And that's something that's going to be challenging, but important.
Great. Now, I'd like to get to some questions that deal with the challenges of doing research in that field and deploying systems. Let me start out with what, based on your experience of conducting research, how does mobile health research differ from typical computer science research, and what challenges do you encounter?
Yeah. Oh yeah, I mean a lot. I mean, one is it's unorthodox, right? I mean, this is a different kinds of research, right? One is, what is the fundamental contribution here, right? For me, it's really looking at, contributions in research can be manyfold, right? One is you're enabling a whole area, right? So in this case, we're using computer science to enable an advanced clinical science, right? So that is a contribution in computing. So one is looking at, is it very applied, or does it have a contribution back to computing? I think it does. So one is trying to make it clear that this has contributions back to computing and in other parts of the scientific world. The one example is that some of the algorithmic development. So by pushing the boundaries of these sensors, we're actually creating new signal processing and analytic techniques that can actually feed back into computing to solve whole other problems, right? The other challenge is that 80% of the work that my grad students have to do is clinical work, right? They have to be working with physicians and clinical researchers to be able to collect this data, create the protocol to be able to do that. So that's the challenge, is that a lot of it is being able to get the data set, curate the data set, and just do the feature extraction. So what's different about this is that the data set is not just available. Like, you can't just have a data set that's available and you can spend 80% of your time doing the algorithm work. A lot of it's the front-end work of just getting to that information, that data. So it does require students to be flexible in terms of the research. The outcomes are not going to be immediate. It could take a year or two, even 3 years before these breakthroughs happen. And the other thing is it also requires to understand the physiology just enough to be able to work closely with a clinical researcher to be able to do this research. So it does require a lot more overhead to just get the data and just to even get up to speed in terms of the disease conditions and states.
What does it take to work with patients in terms of permissions and regulatory aspects? Does that affect you?
Yeah, it does. Across the board, I mean, we're very sensitive to this. Before we recruit a patient or a user, we are very strict in terms of making sure, and we go through all the institutional review boards. So we have IRB protocols. We work very closely with every project with a clinician who actually are working with the patients, and they help us identify patient populations, cohorts. So we go through that because a lot of these are under our user consent. So these are all patient consented. So that's a different regulatory process than building a product under FDA. But one of the things that we do take seriously is that everything's consented. The data is de-identified when necessary in ways that if you ever go down a regulatory path, that data is actually collected in a way that would be admissible, that has not just the scientific rigor, but has the policy and the regulatory rigor as well. So this is something that we do educate a lot of our students in the lab on, because it is a very this data set is very unique, but also you have to be able to think broadly about what the impact of that could be.
Absolutely.
Yeah.
One questioner notes that the initial research on spirometry was published in 2012.
Oh yeah.
What does it take to actually get to widespread adoption among practitioners for these tools?
Yeah, exactly. I mean, the first paper was 2000. It was 12, and then a couple of years later we did SpiroCall, and since that, it's basically we've been fine-tuning it and trying in different use cases. It was also early enough at that time where regulatory agencies were just trying to get their head on what you could do with a phone and diagnosis and screening. But now that world has evolved a lot. So that was that. So now we can start to accelerate some of that, but it's taking some time to be able to validate how you can do it across multiple phones. The other one with SpiroSmart in particular, the technology is not actually the issue anymore. It's actually more the technique. So if somebody doesn't do a proper maneuver, that's the thing that causes errors. So a lot of it's now is an interface issue. We're looking at how do we provide the right feedback to know that, hey, no, you got to keep your mouth open, or make sure you're not doing the technique properly. Because right now the technique is done in clinic, so you can have a nurse next to you that's helping you and coaching you through. So now, how do we do this mediated through a phone? So, so some of the earlier projects like SpiroSmart kind of have paved the way for us to kind of accelerate some of the more recent work that we're doing.
Sounds great. I'd like to ask you a few rapid-fire questions on different types of conditions.
Okay.
One question is asking about mammograms. Do you know any work in that space related to?
Oh, yeah, interesting. Oh, yeah, no. So on overreadings of mammograms. There's actually devices that you can attach to a phone that you can do that go from a global health standpoint. So there is research in that space, and especially in low resource communities. But yes, we haven't done that, but there is work in that space.
How about range of motion for limbs?
Yeah, that's something that we're starting to do a little bit of, where you can start to look at movement and those kinds of things, of frailty. One of the interesting statistics out there is movement is one of the best predictors of mortality. So, which means that from one's gait, how they're hunching, how their gait's moving, is actually one of the best predictors of mortality. So there has to be some vital signal there in movement to be able to leverage that. So that's an interesting area of research, I think.
How about mental health?
Mental health. Think about the stigma of a lot of the conditions like depression, and for mental health, the phone could actually be a mediator for getting help and looking at, even you might not know something's happening. Could the phone be a kind of a proxy or a sensor for that? So that's an area that a lot of researchers are actually starting to look at, not just myself, but this is a community that's evolving.
And perhaps last question for today, what do you see as the great unsolved challenges in this space? Does this involve novel form factors like epidermal electronics, security, or any else that you have?
Yeah. Oh gosh, that's a hard question, but I think it's more. I think it's a combination of trust and reliability. So one is, how do we get these societies, so both the patients and the providers, trusting a system like this, but how do we integrate it in a way that we can actually deliver the care that we think we can deliver? Because you've got signals that are sporadic to signals that are continuous. That world has not come together yet, right? You have the electronic health record world, you have the phone world. That impedance mismatch is very critical. I think sorting that out is going to be absolutely critical. And I think computing has a huge role it can play, because now we've created technology that creates too much data for the physicians. That's where AI can play a role to help triage it. But then how do you close that loop? Closing that loop is the trickiest part right now. So I think it's that building the trust with the with the providers and the patients with this kind of technology that it is possible and it works, and then closing that feedback loop between the provider and the patient is, I think, the hardest thing right now.
Thank you. I'm afraid we've run out of time for today. I'd like to thank Shwetak again for this informative presentation and the insightful discussion to many of the questions. Special thanks to each of you for taking time to attend and participate today. This talk was recorded and will be available in a few days on learning.acm.org. Also, please fill out our quick survey where you can suggest future topics or speakers, which you should see on your screen now. And on behalf of ACM, Shwetak Patel, and myself, Marco Gutesser, thanks again for joining us, and I hope you will join us again in the future. This concludes the talk.